the issue as always with having fantastic visions, and the narrative is that we need to align the mechanisms, the delivery things underneath it, and adopt them with a particular mindset. So we're going to use this next section to drill further into some of the things that have been raised as the opportunities in the policy and the narrative at the moment. The way we're going to do this is we're going to have 3 short sort of introductions to the work streams, because Yvonne, Peter and Ian were significant in leading figures in those work streams, and just run through some of their headlines, and then Alan and Stephen will challenge. Then I'm going to come out to yourselves, so be ready to express your views about the reality versus the rhetoric. Yvonne.
So I have about 6 points I want to make in the 2 minutes. The first is that I had a few aims when I set out as chair of the Health and Inequalities group for the Commission, which was a great privilege. And my aims were to bring focus to the people who live and work in London. To think about how London as a place creates health. In other words, to look at London's assets. Now, I keep getting told, why can't we solve our problems? We've got the most amazing assets if we collectivise those. And perhaps beyond the people in this room, because we need to open new doors and not just use the same old jaded solutions to find the assets and the resource to help us come to some of these actions. London's children. Fairness of opportunity. In other words, not whether we'll grow, we know we will, but the question is how we grow and whether that growth offers opportunity, particularly to the next generation. Lest we forget, in the month of November, my mantra for that was those who make us uncomfortable, those who are in mental distress, those who we walk over often on the streets, who are homeless. They're in this Commission's report. I'm very proud of that. And to learn from our peers. So that's what we set out to do. I'm guessing that everybody in this room has some of those issues on their list, their wish list, and care about this. So it is true when we say that together we want to solve these issues. We did learn a lot from other comparable cities, and in fact we continue to learn from how Manchester has pulled off a very good trick, and back to that in a minute. But we did learn, and we used the best evidence we could find. But just one note on evidence, this is my third point, and it's the only nerdy point I'm going to make. We used experiential evidence and we used analytical evidence. Now, we're very good at the analytical, and there's some lovely pictures and diagrams and bar charts. But my own view is we do not have enough pucka evidence that would pass academic rigour, to say we are absolutely certain you are taking no risk if you do this. And that is where experiential evidence comes in. And I think we need to talk more now about return on investment. In other words, we know cities have done certain things. We are going to say that we would like to do things like that too, including New York. But we're not absolutely certain it's backed up by randomised control trials. And in my books, that's okay. But we do need to have some accountability for, if we're investing in those kind of solutions, what return is there for it, particularly for the cash-strapped local government system. And others, like business, who may invest and want a good business case. What has emerged, in my view, is an extraordinarily elevating set of recommendations. And people in this room are happy. If they've read this report, it is uplifting. You want it. So there's no doubt about that. And it is a report for the people of London and particularly for their political leaders. My own view is we won't make any progress if the political leaders of London do not get behind this report. The challenges it presents us are as follows. We can't argue anymore that we need a fundamental change in the way we approach prevention. Simon Stevens has said it. I'm very pleased our report came out a week before Simon Stevens' report, but they are saying the same thing. And we didn't actually, we didn't steal from that report. This is the way people are thinking. It is a social trend. So we know that's important. Londoners, extraordinarily tolerant people in this dark age of worry about, immigration and all sorts of other things. Londoners are the most diverse and the most tolerant, and they do care about fairness, as do New Yorkers. So the debate about inequalities, we can't park either. You wouldn't want to, but we don't. Londoners are up for this. So what are the challenges? We will make only progress, in my view, if we cooperate. Now, If Florence Nightingale was here at the moment, and I believe she wrote the first report about London, and it was about people, she would say, who is in charge? Well, actually, we're all in charge. We are all in charge. There's no point in landing this on one person's shoulder, but we do need to cooperate in a mature and savvy fashion. That means owning the actions and sharing the risk. In other words, Anne's issues are my issues. Martin's issues and local government's issues are my issues. What can we do? What must we do together? And who collectively do we have to ask for more help? Accounting to the people, I think the 10 ambitions should be things we account for every year on our progress, as New York has done, so that we get the people who were so generous here to give us their views and opinions and their aspirations behind this. To be specific, which is what the Manchester people would say, is London always comes along and says, oh, we could do with more, we want more of that. What do you want? And why do you do it better than national government? What is your business model here? Okay, so we have to be specific, and we're not quite there yet. To be tolerant of our own diversity. So this isn't about, it's all about the mayor, it's all about local government, local is better than national, city is better than, that isn't the way. We all have our, I suppose, our demons on this. We need to park those and find our common cause so that we move together. So savvy, mature, joint approach and a London can make it attitude. And looking for new solutions, not just the old jaded ones, because we're all stressed about finding money. But there are other assets in London too. I think the people of London deserve no less, and I do think London can make it. So thank you very much, and I'll pass over to Ian.
Yvonne, thanks very much. It's a great pleasure to co-chair with Andy Mitchell one of the groups for the London Health Commission. I've just got a couple of key messages and then a couple of observations and perhaps questions for this afternoon. I think we heard a number of messages from the public and the patients that the Commission engaged with, and I want to pick up some of those. There was a really strong call for holistic care. Holistic care, though, that was personalised to the individual, that had choice and control of the care that they received. And in doing that, it was important to recognise that those individuals were also part of groups. And I think one of the strong messages that also came out of the Commission, and a helpful message, was that by better understanding of the needs of groups of patients with broadly similar needs, it was possible to take a more strategic approach to those groups, but very important to recognise the individual within the groups. One of the things, so point number one from me, is the importance of recognising that although those groups may apply generally to London, what does that mean within different areas of London, acknowledging that London is a heterogeneous place? And how do we customise this approach for the specific areas of London that we serve? I was very struck, particularly thinking about the issues of people with serious enduring mental health, and understanding how better, and I think we would all acknowledge that the offer at the moment is not dealing adequately with those patients, and how do we improve that offer. And what was helpful, I think, through the personalisation and engagement offered by the Health Commission was to look at the needs and wants of those patients, and particularly, for example, in the severe enduring mental health group, really the strong message around the need for outreach, for coordination and integration of services, and then the access to specialist care, and how do we make that happen. What was helpful was that, coming back to Yvonne's point, trying to develop an evidence base for what happens and how can we deliver those things that we already know make a difference. We'll hear a bit more about those this afternoon. And then what must be different. I just want to pull up a couple of things here. One of the major changes that I think we'd all acknowledge is the changes in the setting of care and the delivery of care into the community and the absolute preeminence of general practice and primary care in that. A reflection at the moment, it's interesting, having given this talk a couple of times, in the message, and I build on Mark's point that general practitioners and primary care are the solution to many of the issues that face Londoners. I think what our GP and primary care colleagues are hearing at the moment, both in the Health Commission and in the 5-year forward view, is that in some way they're the problem. And we've got to find ways of addressing that, because that is definitely not the case. And we've got to find ways of joining up and integrating as deliverers of care in a way that best suits patients, but not, my second point, to be obsessed with the architecture. I was very struck in one of the commission sessions when the professionals in the room had spent about 30 minutes talking about the architecture of the care system in London. And a patient put her hand up and said, "I'm not interested in any of this. I just want great care. It's the function I'm interested in, not the structure." And I think we've got to find ways through that particular discussion. A lot of time in the Commission actually, again, building Yvonne's point and Anne's point, how are we going to make this happen? And good suggestions. I think the first thing I've taken from is to maintain engagement with London's people, population and patients. If we don't listen to what the population are telling us, then we're going to design something that's not fit for purpose. A very strong message around better information. There are clear issues that we all have at the moment with both the transfer of information and the ability to demonstrate in a transparent way the quality of our services, and that is clearly something we've got to address. There clearly are opportunities in London to look at new funding models, for example, capitation models for long-term conditions, and I think we have to be bold and take some of those steps. In terms of provision of new estate, perhaps new ways of looking at how we handle our old estate, very struck by the fact that I think London's NHS occupies 3 equivalents of Hyde Park. We've got a massive estate in London, and how are we using that effectively, and could we use some of that to pump prime some of the changes in community and primary care? And then a very strong message around that training our staff in the future and the workforce is important. I think the last observation, though, is, well, so what? And I guess one of our challenges, and the challenges that perhaps we'll discuss this afternoon, is about ambition. How ambitious could we be in a world city beyond where we are at the moment? I think it's about pace, because I think we've all experienced, and to some extent, we already know these answers. There aren't many people in this room that don't know the answers that the Health Commission was going to come up with. So the question is, why haven't we delivered? So what do we need to do to be ambitious and deliver at pace? And I think that's probably where I'll stop, Mike.
Okay, thank you, Ian, and thank you. And Peter.
Thanks, Mike. Good afternoon. Thank you firstly to the Mayor and to Aradazi for providing leadership and also the guidance to provide collaboration. In front of you, you've got these lovely cards that says London Healthcare Themes. And on the bottom right box, number 3 down, is system collaboration. One of the things that marked the work on the health economy, the research and the education portion of the London Health Commission, which is what led to one of the top 10 deliverables, which is the Digital Institute, was the nature and the construct of the expert group that was put together. And I would commend to you that that collaboration needs to be beyond your thinking of the boundaries of it at this stage. The courage that was put into bringing that group together was significant because we had some very diverse people. We had the evil finances from the city. We had some great guys from digital venture capital. We had some great people coming in from private equity, that were pure play health private equity. Yes, we had consultants in the room, and I'd like to give some credit to Mo Misra, who did a fantastic job on this. We had digital entrepreneurs from small startup businesses. We had the third sector. We had big corporates. We had the huge pharmaceutical companies. We had big medtech and diagnostics businesses. We had health leaders. We had the AHSNs present. We had a huge spectrum of people. Without that collaboration, we wouldn't have got the outcome in the report. And again, I would say that if we want to deliver anything, and the crucial thing here is not the report itself, but the delivery, if we do want to make a difference to the people in London and give them the right to have a fantastic, healthy future, and in this instance, driven through their access to digital technology and the utilisation of digital technology to enable better care, then we need to think about collaboration. And as I look around the room, I guess I feel a little lonely. I'm the only guy from industry. And I would say that I think that, again, coming back down to the point on leadership here and some of the values and behaviours that are behind me on this slide, is let's think about the inclusiveness and what we mean by inclusiveness and bring in industrial partners to assist. Very happy to do that. The last comment is the academic health science networks in London are a fantastic glue for the future. They are not just about health, and as I look into them from an industrial perspective, they really are a perfect opportunity for us to bring together the broader health, social care and public health landscape, and of course into local government. Thank you.
Thank you. So Stephen, I'm conscious that you do have to leave because you have a train that you have to get, so I'm going to give you first shot. What do you think are the keys to making this report, these reports, this time, something different to that we've had previously?
Well, listening to the contributions so far, the thing that seems to me to be the strongest theme that comes through is a recognition that the health and care sector faces a period of change. And I just want to dwell for a second on that word change and what it means, because that seems to me to be at the heart of the issue. I heard somebody quite recently say to me that the modern world is disorienting because the pace of change is getting quicker all the time and we don't know what's just around the corner. And somebody else said, yes, reflect on it for a second. The pace of change is disorienting, but it will never be so slow again. Understanding that we're in a changing world and understanding why it's changing, the burden of disease is changing, the opportunities created by technology are changing, all of that, and the financial pressures, and we know the quality issues that exist in too many parts of the system. All of these things are driving a pace of change which we have never experienced in the health and care sector before. So reflecting on that, reflecting that it's been too slow and that it will never be so slow again, seems to me a good starting point. And against that background, the challenging question that I would ask is, we all know what the exciting new ideas are. How good are we at recognizing where the current system doesn't work and what we need to stop doing? Too often, innovation in health and care is slowed down because people have habits of behavior and proven ways of doing things, quote unquote, that they're not willing to subject to challenge based on evidence. So, number one, get comfortable with the proposition that what the Health Commission report is talking about, what Simon Stevens is talking about, what the World Economic Forum was talking about a bit longer ago, is the same it's the same challenge as faces health and care systems across the globe. It is of an unprecedented pace of change that is going to get quicker. And change means that we do new things, but it also means we stop doing things. And have we identified the things that we're going to stop doing in order to ensure that we unlock the opportunities to do it better in future?
Thank you, Stephen. Alan.
The problem about sitting on a panel with Stephen is that I always agree with him, which is why we can't really speak for our respective parties. But a couple of observations. I think it's very interesting that you've had what happens every 12 and a half years in the National Health Service.
Somebody produces an act of parliament.
So it's a double act. I didn't realise it was going to be a double act. I should have kept them apart.
I'll tell you what happens. There's a crisis. You can almost set your watches by it. There's always a crisis. And then what normally happens is one of two things. Somebody produces either a bloody big plan or comes out with a bloody big check. And this time, there's neither. This is the first time in my experience around health policy. I've been around it 25 years, and you've been around it, so we've got a half century chalked up, which God help us. It's the first time, the 5-year forward view, where the answer hasn't come from politics. The answer has come from the National Health Service. The London Health Commission report has come, as we heard, from Victoria and Anne. Where has it come from? It hasn't come from up there, it's come from down here. And I think that is a remarkable change. In it, there is both a blessing and a curse. The curse is that this time, nobody is going to give you the answer. The blessing is that you're going to be able to devise your own. And that is a very, very different world, it seems to me, of how decision-making is going to happen. So I think, notwithstanding all of the challenges that everybody faces and all the stuff that you know about and have to deal with every day, my fundamental sense is one of optimism about a really big opportunity that we have to do something quite fundamental. Because what is also very obvious is that 12 and a half years on, we've reached another inflection point. And what you've had, I think, is the sort of convergence of the short-term factors around money being short and all of that sort of stuff, some ill-thought-through reforms and so on and so forth that we needn't go into, converging with some longer-term changes, demographic change, the rising burden of chronic disease, that have forced two big issues onto the agenda. One, how are we going to address the mismatch between the way that services are provided today and what is actually needed? And this is as true for mental health as it is for physical health. Okay? It's not that we don't have great services and great people, we do. It's just that unfortunately all too often they're in the wrong place. And the second thing, as we heard from all of the speakers, and I thought this was the interesting theme that came through, all the way through, in a world of chronic disease where if I have diabetes, what I do as a patient becomes as important as what Howard or Sam as clinicians do in terms of my lifestyle, my exercise, my food, my choices. How do we reshape the relationship between the citizen and the system? So we've got two quite fundamental challenges to face into, in my view. And the challenge for you guys, I think, is this. If this time you are more on your own, and you are, because politics, believe me, whoever wins the next election is not going to give you the answer. Whether it's Andy Burnham or Jeremy Hunt, they're not going to give you the answer. This time the answer is going to come from below. And the two challenges are, if that analysis is right, and I think it is what underpins both the London Health Commission and the 5-year forward view, what are the things that we need to do in order to reshape services, to address the mismatch between need and the way that they're provided? And secondly, and even more fundamentally, to the public health and prevention agenda, what is it that we will need to do differently in order to make patients and citizens, somebody talked about clinicians being part of the solution. Absolutely right. We've got to stop thinking of patients as being the problem. They are the solution. And I think that is an even more fundamental challenge for us.
Okay, I want to bring in the people in the room, because my listening to what we said was that this is about fundamental opportunity. It's about local leaders working in different ways. We had the idea that institutional leadership is one thing, but now working collaboratively is even more challenging. We know we've got to engage a whole group of people. But the energy of a lot of people in the room in leadership roles is not being consumed with how are we gauging up for this. It's actually being consumed with how the hell do we get through to the end of today and the end of next week. And I think that voice needs to be heard about how do you connect the reality of what's on the in-tray and the phone call that comes through tomorrow with finding the wherewithal to make as profound a change as people say they want to. So I'm really interested if anybody in the audience wants to come in at this point and just kind of say, you know, this is what we're trying to, how does it feel out there to have a great opportunity, but actually a day job that may well be forcing you around the here and now, heads down. And I think it'd be great to hear if anybody wants to respond to that. If not, I'll just ask these guys again. But does anybody want to come in on that theme? Because it feels to me that's the reality of people's lives.
Yeah, I'm Tim Smart from King's College Hospital. I think it's the job of those of us in the sort of positions that are sitting around this room today to create a space in our agendas to devote sufficient time to leading the change that is necessary, and that requires us to strengthen the teams with which we work, so that we have confidence that they're dealing with the in-tray, if you like, and we can concentrate on the leadership issues. Having been here 6 years on Monday, I'm still surprised that people in so-called chief executive positions are required to spend enormous amounts of their time dealing with day-to-day operational issues. I think they should be able to trust the teams that they build and remain, appropriately appraised, so that they can be accountable and make decisions where they need to be made. But they do need to have that. We need to create the space to take responsibility for the change that is necessary.
So that is what it's going to be like. And of course, the culture, in truth, of the health service is that all of you guys spend your time looking up. And we've been guilty of forcing you to do that. Of course, somebody talked about the era of performance management, and it's true. But you're going to have to do something that's completely culturally counterintuitive in order to achieve this stuff, and that is that you're going to have to look down. You're going to have to look down to the populations that you serve, to the people in your organizations. And you're going to have to, as Tim says, you're going to have to free some time in here to get beyond the immediate and think about the long term. Now, I think there is one salvation for you, which is this, or rather two. The eclectic mix of people in the room is what really strikes me. Okay? So somebody said at the outset, isn't it interesting that local government and the National Health Service finally are sitting down together, working together? Isn't it interesting that you've got people from the private sector, even from private equity, right? We're actually working together, trying to find solutions from the public health world, from the acute sector world. And so I think one salvation is the fact that there is a shared enterprise here. And it's the first time I've really seen it. And I think it is a fantastic and powerful and energetic thing. And the second salvation for you is, although people keep saying that, we're going to have to invent some new stuff, and yes, we are. What is very striking for me, and I think for Stephen too, is that wherever we go in the world, I've just literally come off a plane from the United States of America, of all places, 3 words: accountable care organizations. Accountable care organizations. This is a system without organization. Some would say without much care, and definitely with very little accountability. And suddenly, we've got ACOs on the agenda. Alberto is here today from Spain, and he'll talk to you later about what they've been doing for 15 years in Madrid and Valencia to properly integrate care across the pathways, that it's focused on the population and achieves, guess what, better outcomes for lower cost. So it isn't that we're having to stare into a void. There are some answers out here, and there are answers not just in the room, there are answers in other parts of the world.
Can I come in also in response to your question, Mike? And illustrating again, I suspect, the principle that Alan and I, when we appear on a platform, we do tend to violently agree with each other. But the answer to the question, how do you create space to deal with the important rather than only ever dealing with the urgent? Tim is 100% right. That's part of what it means to be in charge of an organisation. If all you ever do is respond to Anne's phone calls, that is all you will ever do, because you will be one step ahead of the tiger all the time. I went to a meeting with picking up one of Alan's points, where the health service and local government were sitting down together to deal with the issue of excessive emergency admissions, excessive focus within unavailability of emergency resources within the hospital. And there was a discussion going on about how emergency admissions could be reduced by some very small percentage, dictated by the targets coming out from Richmond House. And I listened to this discussion for 5 minutes, and I then said to them, forget the target from Richmond House. If instead of meeting some target, arbitrary target that came from somewhere on high, you actually asked yourself, if we reorganized this system properly, what difference could we make to emergency admissions, both the admissions and the discharge arrangements? How could we really change it? The percentage that I was given went suddenly from 3% to 20%. Now, we had people sat in a room working out how they were going to get to 3% or 3.5%, and yet they acknowledged that if they thought about the problem differently, they'd be 20% ahead of where they were then. Now, if instead of focusing on meeting the target, they'd ask themselves a completely different question, which is how we could do this right, they'd find they wouldn't have a call from Anne, because Anne wouldn't have a call from Richmond House. When I was in business, I've always been both a politician and a businessman. And one of the things that used to regularly be said in my business life was JFDI. Just do it. If you wait for the answer to come from Richmond House or Quarry House or even from the estimable Anne, you are waiting for Godot. If you set out to deliver a solution to the problem that is yours and nobody is going to take it away from you, you'll find the phone calls will cease. One other observation. I'm delighted that there is a private equity representative here for one reason, and this is an anecdote from my personal history. When I was first a junior health minister 25 years ago, I looked down after a few weeks in office the list of responsibilities that I'd been given. And far way down the list of responsibilities was something that in those days was called unconventional finance. And I asked the private secretary, what does this phrase unconventional finance mean? And I was told that it meant that in certain very, very discrete parts of the health service, miles away from any attention from journalists, there was a new idea starting to take hold, that if you could deliver care to a required standard within budget, you might be able to find somebody who'll lend you some money or maybe even put some equity money into delivering that care in order to deliver good value, high quality care. I said, that's what in the rest of the world they call conventional finance, isn't it? So thinking about the problem differently, understanding that if you've got a problem and you can deliver a solution, you'll find the people in Richmond House have enough to do elsewhere, and they'll stop making calls through intermediaries to you. So JFDI is my message.
Oh, well, and yes, Stephen, I know you've got to get a train, so would you like, if you want to leave now, but I do have a point in the audience, yeah?
Hello, I'm Gillian Greenup. I'm a CCG chair and GP in Islington. I wanted to violently agree with some of it. So I think as one of the fantastic things about clinicians being involved in a lot of the commissioning is that actually we look across, we don't look down at patients, we don't look up at anyone, we actually do get on and do it. And despite, when I say looking across, what we found so fantastic is working with the local authority, working with local trusts, working with patients. And actually we're doing lots and lots of good things. However, the politics of the system does get in the way. So we hope to be able to continue. We're still very optimistic about what we can do, but I don't see it yet as a system where it's all down to us, because actually there are lots of outside influences that keep getting in our way. So,
point taken. Are you?
Can I respond to that and then go?
Okay, well, I am conscious about you.
Having made the pitch that I just did, of course you're right. This is in the overwhelming majority. It's just an observation. We all talk, rightly in my view, about the importance of a joined-up health and care system. We need to remind ourselves that if we're talking about a joined-up health and care system, tax funding is hugely important to that, but it's not the only source of funding to a proper joined-up health and care system. So the important point, it seems to me, is to recognise that in a system that is largely publicly funded and where the commitment to equitable access to high-quality care is the thing that brings us all together, of course it is true, politics will regularly get in the way, and in particular, it will be, there are issues around politics in the run-up to a general election. Of course that's true. But I used to say when I was Health Secretary, Alan was in those days an opposition spokesman. Or anyone involved in the management of this system in the NHS or in the care system locally is involved in politics. Not capital P politics, but politics. And simply intelligent management of how you manage a change programme around a political timetable is part of intelligent development of your responsibility to your local community. You're involved in the clearest example of this, Her Majesty the Queen. Politicians are never allowed to mention her except with genuflection. But she is involved in politics. She's not partisan. She's not a party political figure. But the monarchy is held in the esteem that it is in this country because the Queen is a supreme politician. Maybe NHS managers should learn a thing or two from her.
Stephen, we'll let you go at that point. I was going to mention people who aren't in the room, but Stephen, please, yeah, it's fine. Thank you, Stephen. Yeah, cheers, thank you. Before we come on, and the next bit of this is really around your tables, responding around the tables to the challenge that said it's all about local leadership. It's up to us, and we've got to find our way to do that. But I am going to pick up with our three people who've been very tolerant of our politicians stealing some of the mic time. I think there's a theme of the partners who, in the future, are part of this coalition of leaders. And Peter, you made the point that you're the only person from industry in the room. Yvonne, I know when we come to health, all the forward progression on health is probably coming out of Nike, Apple, all the people providing all that kind of side. And in terms of breakthrough technologies and the relationships with pharma, medtech in that sector, do we have... is our orthodoxy such that when we put the leadership group together and say it's up to us, we're still thinking statutory, public sector largely, when really, if we were getting this right in 5 years' time, this room would have even more representation from those different groups. It would have to be a quick response, but I'm just very interested in your thoughts on that.
Thanks. And I think Tim Smart's remark about creating time and allowing people to do their work so leaders have the space is really important. Alan Leighton, the guy who came out of Mars, the chocolate firm, went on to run Asda, run the post office, and became a pluralist business leader, was asked, so how the hell did you do it? And he said, by employing really smart people around me who are very capable at doing the day job and giving me the time to think and then execute about change. The resourceful bit in there is think and imagine bringing other people together. You mentioned a lot of industry. The automotive, and particularly Formula One, love it or loathe it, has a lot of algorithms and technology that could play into health. Different space.
I'll come back. I'll let you go last.
Thanks, and certainly, Mike, there are a lot of opportunities within technology. I think I'd move slightly backwards, though, into within this room exists London's leadership. We've already heard about some of the models, for example, ACOs. I'm going to hear a bit more about the Spanish experience. I'd just be interested when the conversations happen around the tables for some feedback, particularly on, well, if that's an answer, which part of London is going to be brave enough to deliver it when? Mm-hmm. Because I think our challenge is, as I've flicked back to my presentation, many of us know the answers. Where is the locus of decision-making going to sit with the ambition to deliver something radically different?
Thank you. Yvonne?
Yes, I mean, I think somebody raised the issue of skills here, and I think certainly looking at the people I know, fantastic up to a certain point, but we do have a skills deficit, for instance, in social entrepreneurship, in knocking on doors, in asking the way, if I were setting up a business, I'd be knocking on Dragon's Den and asking for the resource to get going. We need to ask people to help here, because even this room is too small to do this. It's too much of a burden for everyone here, and it's fantastic to see people I've known for many years, and we need you to keep coming back, because you know you are the faithful leaders, but we need the unfaithful leaders as well, the people who are out there who have other solutions. One of them being we're aiming to digitalise 6 million Londoners to help them help with their mental health. And my colleague Paul Plant has been and Peter Cohn has been very helpful on that. But, you know, we need people to open the doors there. The businesses are coming forward with the solutions, and we need the kind of matching process to actually make it happen.
Okay, and I will give you the last word, because you were, I don't know if it's a non-sequitur from unfaithful leaders, but do you want to come in at that point?
I think it's the other reason I'm reasonably optimistic. You know the best thing I see anywhere in the world in health now? On that thing. The most exciting things I see are on here. Applications to help you monitor your own health, control your own health, and be supported with your own health. This is an evolving paradigm that we are seeing, and it will only escalate in future. And out there, I think there are a group of very willing participants, sort of new entrants, if you like, on the health pitch, who want to come and play. Whether the telecommunication companies, who frankly know far more than we do about how to do telemedicine and telecare. You know, pharmaceutical companies are having to reinvent their business models because their old one is bust. And they're having to work out, how do you not just provide a pill, but how do you provide a service? So, you know, in sector after sector, there's, and you mentioned some of the big boys, Mike, and it's no coincidence, Apple, Google, Microsoft, the latest iPhone was launched on the basis of what? It's health applications, it's health applicability, it's health functionality. So we have a series of willing accomplices out here. I think the question for us is a mindset question. Are we going to continue to be narrow in terms of our mindset, looking up here, or are we going to be wide, looking down there? And if we're wide, there is a genuine opportunity to do what I think is necessary. Because people think that we're having to do these things because money has run out. It isn't that. The reason that we're having to do these things is that time has run out. Time's run out for a system that, frankly, was great for yesterday, but is going to be hopeless for tomorrow. It just is. And this is the moment where the vital ingredient that will make the difference in turning what feels like an insurmountable challenge into a huge opportunity in London and across the country is leadership. Leadership is the most important ingredient, and that's why it's great that you're all here, and I really, really do wish you well. And I think there is, I think you've made a fantastic start with the Health Commission report. And the challenge now, as always, is to use my friend's phrase, to get on and do it.
I'm still trying to work out what the F was. Anybody know? I can't work it out. Listen, right, so we're now into the conversations around the tables. If we can put the slide up that has the ask of you around the table. There are facilitators on each of the tables. If you're on a small empty table, please join others. And we'll make sure that all of what you describe is captured and put into the report that emerges from the end of this meeting. Thank you very much. I've sat on a couple of tables and just listened to the energy, and it's a shame really that anybody from the front who was challenging our desire and our ability to find that time and energy probably hasn't been around to listen to some of the things that you've just been debating, because I saw no shortage of a desire to make things happen. What we've got and will provide for you afterwards is that all the conversations on every table has been captured, and on that basis, can you make sure, if you are a facilitator, that you remember the yellow sticky notes that have got that on. I just picked up on one or two things that I think were particularly interesting and followed very much, but at a level down from the high level and really getting into what makes things happen. Some very interesting conversations, including coming through Twitter, people outside the room responding to the conversation going on about, well, what is the strategy around digital health in London? Who are the partners? You know, what's going to happen to make that a reality? Does it need statutory agencies? Is it really something that will just pass, is inexorable, and we have to find a way to engage with it? We had some very important points raised about, it's fine, we want to get on an act, but there are perverse incentives in the system. It's not that the system is neutral. Actually, there are perverse incentives that get identified very quickly when you try and do things differently. So the relationship between organisations who take on more risk isn't necessarily reflected by their regulatory or performance managers, but they're usually the ones who are being asked to try and solve other people's problems. So can you find some way of recognising that, whether it's coming out of a trust or a local government or coming out of a CCG? Connection with primary care has been certainly something that's been raised. We have leadership through CCGs in terms of the commissioning responsibility, and obviously move towards co-commissioning is going to bring more resources into play. But actually engaging the primary care community at scale still remains a challenge. We know we've got movements to federations, but are they actually being sort of like, are they round the table as opposed to something that's about trying to survive and seen very much as part of the strategic future? There were certainly conversations about the strengths or weaknesses of the BCF as a vehicle for bringing organisations, particularly local authorities, health authorities together, and actually quite different views. In some cases that's been seen as a hugely powerful instrument, in others not. And it's been more of a distraction. So the financial risk sharing piece. Interestingly, people talked about health and wellbeing boards as well. What is their role in this? Are they critical, or are they something that is still not quite central to the agenda that we discussed? And I will end on this note, because we're about to do some more networking. A recognition that even where you have the incentives, the narratives, everything in play, actually the quality of the relationships between us as leaders, the trust that we have in each other, the way in which it's not always about longevity of relationships. Sometimes that means that you get the scenario of, well, in 2003 you screwed me, so I'm just waiting for my chance in 2016. It's not always about longevity of relationship. It's about the quality and the integrity of the way you conduct yourselves, which very often, and in the immediate term where everything isn't aligned, is the way that you can make progress. And so building trust, familiarity, understanding each other, open book, real high quality relationships between leaders is absolutely critical in the short term. So listen, what we're going to do now is we're going to break for 20 minutes for coffee. We're going to move from thinking about the London Health Commission, which has been the starting point, and that go back to my framing piece right at the beginning about how you've got the opportunity of a sense of place. And the next session is going to be focused, in the first bit at least, on activating communities and patients. And we've got some really interesting data and information to bring you